Welcome to Drugs Used to Treat Ear Disorders and Primary Care. Otic preparations should not be used if the tympanic membrane is perforated. This includes tympanostomy tubes. An exception to this rule is that the quinolones, like ciprofloxacin, and quinolone glucocorticoid combinations are safe for patients who have perforated tympanic membranes. Installation of cold solutions can cause dizziness, therefore eardrops should be warmed before they're administered. Warming should be to body temperature and can be accomplished by holding the container in the hands for 5 to 10 minutes. Never heat it in a microwave. Lie down or tilt the head so the affected ear is up. For an adult, hold the pinna up and back, and in children, hold the pinna down and back. Maintain the position for 3 to 5 minutes after installation. To be diagnosed with acute otitis media, the child would have a history of acute onset of signs and symptoms with the presence of middle ear effusion and signs or symptoms of middle ear inflammation, indicated by distinct erythema of the tympanic membrane or distinct otalgia, ear pain. Acute otitis media should not be diagnosed in children without middle ear effusion, and that's based on pneumatic otoscopy and/or tympanometry. The most common organisms are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Do you remember if these are gram-positive or gram-negative organisms? You need to check that out. Most episodes of acute otitis media resolve spontaneously. Mild cases with unilateral symptoms in children 6 to 23 months of age, or unilateral or bilateral symptoms in children greater than 2 years old, may be appropriate for watchful waiting based on shared decision making. Observation is an appropriate option only when follow-up can be ensured and antibacterial agents started if symptoms persist or worsen. Non-severe illness is considered as mild otalgia and fever less than 102 degrees in the past 24 hours. Severe illness is moderate to severe otalgia or fever greater than 102 degrees Fahrenheit in the last 24 hours. A certain diagnosis of acute otitis media meets all 3 criteria: rapid onset, signs of middle ear effusion, and signs and symptoms of middle ear inflammation. Antibiotic benefits don't always outweigh the risks. In fact, about 20 kids need to be treated with antibiotics to prevent one from having ear pain after 2 or 3 days. But 1 in 14 kids treated will have diarrhea, vomiting, or rash. Amoxicillin remains the first-line therapy for children who have not received amoxicillin within the last 30 days. Amoxicillin clavulanate is recommended if amoxicillin has been taken within the last 30 days. If there's concurrent purulent conjunctivitis present, or if the child has a history of recurrent acute otitis media unresponsive to amoxicillin. The drugs listed here is one situation where you need to know the specific dose and frequency. Now, some other things for children with allergies. You can give a cephalosporin, such as cefdinir, cefuroxime, etc., for kids with non-severe reaction to penicillin, such as a non-itchy rash. Save the alternatives, such as clindamycin and levofloxacin, for most kids with a severe penicillin reaction, such as hives or angioedema, or as a last resort for resistant infections. Don't use azithromycin or TMP-SMX. They no longer cover the typical bugs that cause acute otitis media. Use a shorter antibiotic course if appropriate. For patients without severe symptoms, lean towards a 5-day course for kids 6 years and older, or a 7-day course for kids ages 2 to 5 years. Shorter antibiotic courses may work just as well in these kids, with possibly fewer side effects and less resistance. But stick with 10 days for kids under age 2 or with severe symptoms. Recommend acetaminophen or ibuprofen for pain if needed. Keep in mind that prescription eardrops for pain, Aralgan, are no longer available. Otitis externa. The two most common bacteria are Pseudomonas, which is water-loving, and Staphylococcus aureus. Treatment is to include gentle cleansing. I've never had a patient who would allow me to do this because their ears are so tender with this infection. If it is moderate to severe disease, I've never seen mild, the Sanford Guide offers the combinations listed here. Unfortunately, they are all expensive. If no relief in 2 to 3 days with treatment with one of these, the provider should be notified so that prescription regimen can be changed. You might want to consider a possible fungal infection at this point. I would know these antibiotic names, doses, and frequencies. Oral antibacterials are indicated if the infection extends beyond the external auditory canal to involve the pinna. For adults, ciprofloxacin is a good choice. However, because oral quinolones can cause tendon rupture in younger patients, it should not be given to patients younger than 18 years of age. For children, cephalexin is preferred. % acetic acid or alcohol drops, which are made of 1/3 portion white vinegar and 2/3 portion rubbing alcohol, can be used as a drying agent by individuals prone to recurrent ear canal infections. Ointments should never be used in the ear. In about 10% of patients, otitis externa is caused by fungi and not bacteria. The two most common pathogens are Aspergillus, which causes 80 to 90% of otomycoses, and Candida. As a rule, otomycosis can be managed with thorough cleansing and application of acidifying drops, the 2% acetic acid solution applied 3 to 4 times a day for 7 days. If these measures are inadequate, the patient can apply a solution that contains an antifungal drug, such as clotrimazole, twice daily for 7 days. If the infection fails to respond, oral antifungal therapy may be needed. Options include itraconazole and fluconazole. Thank you for your time and attention.